Okay, guys, I had to move my wife's in my normal spot. Um, just a quick talk on the um, retroperitoneal exam, and that's it for today. I don't have time, unfortunately, to do a whole lot else. So let's share this screen and just quickly talk about this. This is in my way, isn't it? There you are. Just low right here. That should be better. Okay. My normal. Okay, I don't know how to use that without a regular mouse, I guess. Oh, I guess I could use my, all right, enough of talking about things you guys don't care about. Okay, so the retroperitoneal. Retro meaning behind the peritoneal cavity. That consists of, well, one aorta, two IVC. Why? Because these are both in the retroperitoneum, and therefore and easily discoverable by ultrasound. So therefore, they are in the the picture as well. And of course, there's any masses you see in this area, like lymph nodes, or any cancers, normally we don't see. Just make sure I am reporting or recording. Normally we don't see the adrenal glands, but if you were to see the adrenals, that would be something else to note because they're probably bad. So one aorta, two IVC, three both kidneys, and then those are the requirements. And then four, surprisingly enough, the bladder is not technically a requirement. However, you're going to be doing it. So let's add my, oh great, I really need my other screen. I don't know how to work this without two screens. But yeah, so aorta, IVC, kidneys, bladder. Now, one of the things that we've mentioned in class, and it seems some of you have a hard time really understanding what I'm saying here. Well, actually, let's start aorta. Aorta, maybe three images, two to three images of the aorta in sagittal. We don't need, actually, you could even get away legally or hitting the most basic requirements. You could do one image of a proximal aorta. But knowing that AAA is a killer, it's probably a good idea to at least take an image more proximal and then another image a little more distal and try to get the mid to distal sections as well. So you really should be doing 2 to 3 images at a minimum of the aorta because AAA is a killer. IVC, on the other hand, 1 to 2 images are fine with the IVC. There's not a whole lot that we have to worry about. There are some things, thrombus in the IVC. If there's any kind of known issues or known renal cancers or anything like that, you might want to take a second look at that IVC because cancer can go from the kidney into the IVC pretty easily. The kidneys now we're talking about, let's see, 10 images per kidney. So that, I think, is the part that some people, some students have a hard time understanding, because you're not out there. You're seeing us practice here, and you're not quite getting why we would do 10 images. And so let's just quickly draw a kidney here. I can draw the right or the left, doesn't matter. I'll just draw what appears to be the right kidney. Let's just do a little collecting system here. I have a hard time. You usually don't see too much of that. And of course, there's blood vessels coming in. And then there's the center of the kidney. And I'll just draw quick lines to indicate the bases of the pyramids. So, and that's good enough for now. So let's get another color. So I usually start with sagittal kidney. Actually, let's start like this. Let's say we do my first image dead center on the kidney, right about like that. Well, if it's dead center and I've got it basically as long as it's gonna be, let's put a caliper here. This is my scan plane, but then we'll put a caliper here, and we'll measure that length. Of course, on our imaging, that kidney is not straight up and down, because but in any case, I can show you what a kidney image would look like with this, but let's just go ahead and do a caliper. And then image number 2, and you don't have to do it this way. Image number 2 is going to be, right about here in transverse. So first a sagittal, then a transverse, and then of course on that one though, well, that image is going to look, right, we need to draw what the kidney looks like in transverse. It doesn't quite look transverse enough. Let's just make a C. Thickened bubble C, like you guys did when you were kids, your bubble letters. A transverse section of this is now going to look a little, we're going to measure, I prefer to measure, so this is number 2. This is this plane right here coming across. We're now looking at our vision, our view of the kidney is now a transverse view. And some people will tell you that you always measure, whoops, I thought that was in, that you always measure across, like make it like that. No, I don't think so. Or some people will say, well, no, let's make a plus sign. Well, no, not necessarily. What I like to do is I look at technically speaking, the height of this would be from, well, an imaginary line. If we could close the C, we can close that C from here to here. Just imagine that line, and then we actually put our caliper across there. That would be the height. And then the width goes from side to side, really. Now, if anyone calls this width and that height, I could care less. Does not matter to me. Does not matter. But in any case, we now have our 3 orthogonal measurements in the first 2 pictures of this kidney, which is kind of nice, just get that out of the way. So I propose doing that. You don't have to do it that way, but I propose getting your measurements done. And then the next thing we do is we go back to sagittal. Let's use a different color again. And on my sagittal images, I am going to be doing this. Picture number 1, well, I'm going to scan all the way out to here, but I'm not going to take that picture out. The red lines will be the actual pictures. So I'm scanning out beyond the kidney because, well, here, let me draw something in, which happens all the time. Exophytic cyst on the outside of the kidney. Maybe even a tumor on the edge of the kidney. And so you want to be seeing that, so you're going to look beyond the kidney. So once again, red line. What the heck just happened there? I forgot this. That's one color, and go back. So actually here, green line will be, I'm scanning out to here, and I'm scanning out to here, and I'm catching, I'm saying, oh, there's a cyst. Well, now that I see a cyst, my first image is going to be outside of the kidney because there's a cyst there. I got to take that picture, and I'm doing the sagittal images here. And so maybe I'll do that. I'll come in, image, and then I'm going to continue to image through the kidney. The red lines are the actual pictures I am taking. Let's see. I have a couple of extras because there was a cyst out here, but if I didn't have that cyst, I would have 1, 2, 3, 4, yeah, 1, 2, 3, 4, 5 images perhaps. And then I'll be done with my sagittal. And let's go back to, let's do a nice sky blue. And I always start actually start with green again, because green indicates where I'm scanning, not necessarily taking pictures, but I'm scanning out here, and I'm scanning down here. But my actual pictures are going to be here. 1, 2, 3, 4, 5. Well, on this one, I'm going to take maybe take 6 images. So I'm going beyond 10 images on this kidney. I've done 2 images for my measurements, and then I went, let's see, 5 images, minimum of 5 in sagittal, and minimum of 5 in transverse. So that's 12, and considering I took a few extra pictures, I probably took 15 images of this kidney alone. But you could see, look at this grid pattern now. Have I missed anything? Have I you know, when we include the pale green, the light green here on the outside, actually I could have even thrown a couple of those out here as well. The light green being imaging I did without actually taking a picture. In other words, just scanning through. But then the red and the blue and the dark blue are all actual images, all actual scans. And so is there any part of this kidney that I've missed? That's the point. That's what I'm trying to say when we take multiple images, sagittal, multiple images, transverse, we get all of those. And then, of course, we repeat the same thing on the other side. When we come down to the bladder, bladder is, once again, and let's see, in transverse, I would use green for that. In transverse, a full bladder is remarkably square. Remarkably square. It's just the way it fits in there with the psoas muscle and the hip bone over here, another psoas muscle and a hip bone. We could, and that's in trans. A trans bladder, and then a sagittal bladder looks a little different. Let's move over here. Sagittal bladder tends to, how does it look? It tends to look I can't think. Let's see. Let's put a uterus in here. Okay, that makes it easier for me to think about what a bladder looks like. A little more triangular. Here's a not my uterus. That'd be weird. But here's a bladder here and here. Well, the first thing we're going to do, let's get the measurement out of the way. Let's get that measurement out of the way. And so, or yeah, let's go ahead and do that. So we'll make measurements a pretty color of blue here. We're going to go to the caliper on our machine and choose a, I forgot what it's called, but basically it's a volume, a three orthogonal volume. So let's see, we could do and I don't care, honestly, with this one, length, width, height, whatever. Those are 2. And my third, well, here's the thing, guys. If I put my third up here, you could see where I'm kind of overestimating the volume, because that's obviously not a representative line for this entire thing. Just as if I put the line down here, I could be underestimating that volume. Does that make sense? Because of the triangular shape of this bladder, I think it's best to kind of take kind of feel like you've taken a fair guesstimate, and this is a guesstimate, your decision, not mine, it's your decision, you are the tech, on where to put that third and final measurement, and then it'll give us a nice volume of 100 cc's or whatever, or by the way, cubic centimeter cc's is the same as milliliters. A cubic centimeter is equal to a milliliter, so I should put an equal sign there, just so you know. So 100 cc's, 100 milliliters, same difference. Could be 1,000. Is it 1,000? 1,000 would be like a lot. That'd be a full bladder. 100 cc's is a pretty empty bladder, though. Anyhow, so we got that measurement out of the way. And then once again, we can go through this bladder and we could, well, let's look at the sagittal. The bladder's a little bit different to imagine. We're looking at it sagittally, but here are my transverse planes. All right, so I take those pictures, and then let's see, looking, how would I draw? No. So then my sagittal pictures would be kind of across. So probably more pictures than we really need on a bladder. The bladder is kind of a boring thing. So maybe I've overdone it on these lines. So maybe 1, 2, 3, 4, 5, 6, 6 to 8 images on a healthy looking bladder is fine. Plus your measurements, picture or pictures, if you need 2 pictures to do that. And then the last thing we want to look at, and generally in transverse, so let me redraw the bladder here. I'll put it over here. We're going to try to find the jets, the ureteral jets. Now, a lot of times we go looking for, there could be a lot of posterior bladder, and of course the jets come in from the posterior surface, right? And so where do we find that? So let's kind of draw our square-ish bladder here. And sometimes we could actually see, really faint usually, unless there's something wrong with them, the ureters coming in underneath. But if you can't see those and you're kind of wondering where to go, what you could do is so in a transverse view, just rock the transducer farther and farther caudal, inferior end. And eventually you will actually, a male or female, you will run into a faint shadow, and that is the urethra. Now, the urethra is part of the trigon. So if we look straight down on the trigon, it would look, and there's a little ridge. We don't see the ridge. Well, honestly, we don't see the trigon either. So for that matter, it is what it is. So there's a ridge of little harder tissue around, and this is all part of the bladder muscle, a bladder wall, bladder muscle. Trigon is right ureter, left ureter, urethra. So if you come inferior to the point where you see the urethra, and in the male, it's going to be going right through a prostate. In the female, you're not going to see prostate, of course, but you will see a urethra. So you come down to that level. Well, now you know that all you have to do is back it up, go a little bit more superior, and you'll be really close to that level. You still might not see the ureters all that well, but if you sit there and wait and the person's hydrated, if they're not hydrated, it's a real pain. But if they're hydrated, you will eventually see a jet, another jet. They don't quite look like that, but urine comes in at a high rate of speed. Why is that? Why a high rate of speed? Why not just dribble in from the kidneys? Well, the ureters are muscular, and they're muscular for a couple of reasons. One, they're going to use peristalsis to squeeze that urine down into the bladder. But why does it have to squeeze down? Why can't it just kind of drip down through gravity? Well, okay, one, we're not always standing up, and so you still want urine to go into your bladder even when you're laying down. That's one obvious reason. But the other not so obvious reason is that, remember how these so-called valves of the bladder work. If I were to draw a ureter coming in underneath the bladder walls, something like that. Let's see, and these kind of continue through the wall, of course. And then so what we don't want, we want one direction of flow. We want urine to flow from the kidneys into the bladder. And so we have a it's a valve. We call it a valve. It's not really much of a valve. All it is really is that the weight of the bladder pushes down and squeezes this out so that it remains closed until urine, might as well make that yellow, huh? Urine is forced through and opens it up. And then when it stops being forced through, it slams shut again. So basically it's a valve, because you don't want reversal of flow. That's bad for you. It's bad for your kidneys, and especially bad if you were to get a bladder infection. You definitely don't want reversal of flow or reflux of flow back to the kidneys, because then you will get a kidney infection very quickly. Okay, so retroperitoneal, once again, aorta, IVC, aorta, 2 to 3 images, both the aorta and IVC. Man, if you only took one image, you're technically there, but it's just not it's not doing due diligence. You're not doing the patient any favors. So 2 to 3 images of the aorta minimum, as far as I'm concerned. And you want to look at that proximal and mid-distal aorta, because triple A is a killer, so we don't want that. IVC, a little less important. If you have a nice view of the IVC proximally, you're probably good. If you want to do another image down low, lower in the belly, that's fine as well. Kidneys, 10 images minimum. When I was imagining this kidney, I was probably doing closer to 15 images, or at least 12 images. So it's 10 images. Why? Because we have to prove nothing wrong. And you know what? And I've had some questions about what exactly are we looking for in the kidney? Okay, well, most common, cysts. Usually not a big deal. Cysts, we see them all the time, but you want to know if they're there. Hydronephrosis, tumor. Tumors will kill you. And last but not least, calcs, or actually that's not last. Calculus. We see little echoes all the time in the kidney, especially in the collecting system. If they're shadowing, then it's an actual calculus, and you can call it a calculus. If these other things are not shadowing, you could say non-shadowing bright echo scene, but make sure you say non-shadowing, because you don't want to give the impression of a calculus when it's actually not. And then there are a number of, I'm just going to put meta for metabolic issues. Medullary sponge kidney, nephrocalcinosis, renal medical disease. So the kidneys can have an off texture and off look for certain issues, sometimes from drug overdose or something like that. But that's basically what you're looking for. Anything wrong: cysts, hydronephrosis, tumors, calcs, metabolic issues, really thinned out kidney. So a kidney that is, its collecting system is all the way out to there, and you have a very thin cortex and a thin parenchyma in general. And so those are the kidneys. You do both of those. And then bladder, not a whole lot going on with bladders, but we look, we pay attention. What if there was a stone right here? I've seen plenty of stones right there at the ureteral vesicle junction stones. So we're looking for that. Of course, it has to shadow. We're looking for, if there's a lot of, maybe just a couple crystals, not a big deal, crystals of urea. But if there's a lot of floaters in here, well, that might be an indication of something wrong. You shouldn't have too much floating in your urine. So that's something to mention as well. If the wall of the placenta of the bladder is extraordinarily thick, we are going to take a look at that, and we'll probably measure the wall. Normally, I wouldn't suggest measuring the wall every time, but if it looks thick, go ahead and measure it. And Doppler it. Throw Doppler on there and see if it lights up like a Christmas tree, then that's probably cystitis. Isn't that weird? It's called cystitis rather than just call it bladderitis. Of course, I forgot to mention if you're going to see jets, obviously, you need you need your color Doppler on. But we're going to look at the jets, make sure that there's flow coming in from both kidneys. This is a real pain if the patient is not well hydrated. These guys come in, it could be 5 minutes waiting, and when you're busy, that's not fun. So hopefully your patients are well hydrated. And drinking a water as they're walking in the door does not count for well hydrated. By the way, a lot of people think that counts. It does not. Okay, that's all I have to say about retroperitoneals. I will add something. I need a little more width. Let's keep it on that side, and 2800 should give me enough. Women, we're going to talk all next semester on other things in the female anatomy. But generally, if you're doing a retroperitoneal, you would only pay attention to ovaries and uterus if there's something obviously going on. You can't help but see it. Don't go looking for it. It's not your job. But if you see it, it's right there in front of you, then you are allowed, and in fact compelled, to mention it. Let's just do another couple of images of the bladder. And from a male's perspective, oh God. I think I'm doing this by memory, and I'm really having a hard time remembering what a sagittal bladder looks like. I don't know why. So, male anatomy. Okay. Not necessarily a part of the exam. That is not a cracked egg. That is a prostate. Get to know what a prostate looks like as far as size goes, and you can go ahead and measure them until you get a feel for how big they should be. A prostate should be not bigger than about 26 cc. So you could, just like you do with a bladder volume, you can do a volume here. Let's see, let's do like we want to go across there. We'll go from here to here, and then we need one up and down. Hey, do you need to be leaving right now, honey, or? I could pause this. Okay, guys, looks like I might have to be heading out the door real soon. That's okay, we're pretty much done. So anyways, if you take 3 orthogonal measurements, 26 cc's is about the highest that it is supposed to be. Beyond that, it starts to become enlarged. Let's see. That's really all I wanted to add. So, if these things can grow to comical sizes. I've actually seen this. That's obvious. If you have a prostate that has that size to it or that dimension to it, that's obviously enlarged. Otherwise, there could be just overall enlargement as well. So just keep an eye out for that. Okay, that is it for today. Hopefully I'll get this sent to YouTube. It does take a few minutes for all this to happen, so we'll see if I get this on the YouTube before I leave.